We're going to start this morning talking about interstitial lung disease. And what I'm really talking about with you is a radiographic pattern of interstitial lung disease. I don't want to be too concerned about whether it's truly interstitial or not, but if it looks reticular, nodular, or even small nodular, all that will fit into this discussion. The differential diagnosis, if you wanted to talk about all the diseases that potentially could cause an interstitial pattern on a chest radiograph, they're probably in excess of 200. To roll off a differential of 200 things is not useful. It is not useful to anyone, and it's unnecessary. But what you do want to do is have the big categories in mind, so that if you encounter the disease, you can at least talk about the things that are likely to be the cause. And so what I'm going to give you now are the things that roughly cover about 85% of all of the interstitial diseases that you encounter, and that'll at least get you started. First of all, if you see reticular, nodular, or small nodular disease, you always want to think about interstitial pulmonary edema. The reason for that is, one, it's very common, particularly in a hospitalized patient. Secondly, you don't want to be going through a huge workup for someone who actually has interstitial pulmonary edema. You want to keep in mind tuberculosis and the pneumoconiosis. Those two categories, again, frequently create a radiographic pattern that we refer to as interstitial lung disease. You want to keep in mind sarcoidosis and PCP. Again, two diseases that we encounter not infrequently. And finally, the interstitial fibrosis diseases, including UIP, drug toxicities, collagen vascular diseases, and lymphangitic tumor. And finally, on this differential, eosinophilic granuloma. If it's none of the above, that's a good thing to talk about. Now, if you look at this particular differential, it's actually constructed in a way, if you memorize it in this order, that should be helpful to you. That is, the most sort of common thing that you want to think of first is interstitial pulmonary edema. The remainder of these, as you'll notice in a moment, and I'll reinforce this in just a second, are given to you in the order in which you may see them on the chest film. So tuberculosis and the pneumoconioses generally affect, in the early stages, the upper lung zones. Sarcoid and PCP generally affect the mid-lung zones in their early form. And the early forms of interstitial fibrosis and lymphangitic tumor actually affect the lung bases early on. And if it's none of the above, then eosinophilic granuloma. So we have the most common first, the least common last, and the rest of these are basically sort of a geographic distribution. Now, I'll caution you that this geographic distribution really only works if you're early in the disease process. As you get later in the disease process, obviously the disease spreads to involve more and more of the lung, and that geographic distribution may not work quite as well. Now, clearly the hallmark of interstitial lung disease is the demonstration of septal lines, or as shown here, what are often referred to as Curley's V lines. These lines at the lung base that hopefully you're all familiar with, basically about 1 centimeter long, extending out to the pleura and stacked one over the other. If you see lines like this, you know you're dealing with interstitial lung disease. And of course, for those of you who are followers of Curley's lines, these are Curley's A lines, upper lung zone radiating from the hyla obliquely outward. These lines were described by Dr. Curley and have caught on certainly with our friends in internal medicine and other places, but they are sometimes confusing in the sense that if you start talking about Curley's lines, I guess everybody knows about Curley's B lines. As soon as you get to Curley A lines, all kinds of questions start to come up. First of all, the lines aren't curly, they're straight. They're actually named after Peter Curley, who described them. Secondly, when you start talking about A lines, B lines, C lines, it's a little hard to remember what they all are. And the worst question, of course, is an A line more significant or better than a B line? And again, when you're talking to people in medicine, their natural inclination is an A is always better than a B, right? And you guys have all gotten here because you like A's better than B's. But it turns out that A's and B's are really no different. They essentially represent the same thing, and that is the interlobular septa that separate secondary pulmonary lobules. So if you look at a gross pathologic specimen and look at it from the outside, you can see that actually the lung is divided into these secondary pulmonary lobules by interlobular septa. And it is these interlobular septa that we are seeing as septal lines or the Curley's lines. And the reason that A lines and B lines look different has to do with the pathologic organization of the lung. And what you'll notice is that at the lung bases, interestingly enough, the septa tend to be organized in a horizontal fashion. So you see them all here, organized in a horizontal fashion. If these lines thicken, if these septa thicken, you're going to see on the radiograph those lines that are described as B lines. As you move higher in the lung, interestingly enough, that pattern breaks down and you begin to see obliquely oriented lines, and those are the A lines. And obviously the C lines that Curley described are kind of decision of all this stuff. So what we recommend is, as the easiest thing, is forget about Curley's lines. It's good if you're talking to internists. But when we talk among ourselves, we generally refer to septal lines. Lines all have the same significance. Now let's look at some actual cases. Here's a diffuse interstitial lung disease, reticular nodular, scattered throughout the lungs. Again, this is the most common cause of an interstitial pattern. This is interstitial pulmonary edema. The tip-offs are that the pulmonary vasculature, in this case, since it's secondary to congestive heart failure, shows evidence of redistribution with more flow in the upper lung zones. The heart is enlarged, and often in this setting, we do see septal lines at the lung base, as illustrated here. So this is a very straightforward case. It's pretty easy, and you're not usually going to get into a big discussion about interstitial lung disease, except if you see it the first time and you don't have an old film available to you, it's a little hard to be sure about whether it's edema or it's a more chronic interstitial lung disease. And obviously, sometimes the way to approach that is to treat the patient symptomatically with diuretics, and this will resolve and you don't have to work it up any further. Let's move on to the more interesting sort of groups of patients. We'll start with tuberculosis. Again, we talked about the fact that it has an upper lung zone distribution. That is true in the setting of post-primary tuberculosis. That is a second infection. As you know, in post-primary, whether those are really recurrence of the original infection or a second infection is not entirely clear. But it is true that in the post-primary pattern, you tend to involve the upper lung zones with the interstitial lung disease, the apical segments of the upper lobes and the superior segments of lower lobes as well. And these are fairly straightforward cases. There is, of course, a variant in the tuberculosis category, which is the small nodular pattern, it's shown here, with diffuse small nodules throughout the lung, often referred to as miliary pattern. If you are familiar with millet seeds, which virtually no one is, this is what they would look like if scattered on the film. Again, in this particular case, the pattern is often a little bit different and may show something of a basilar distribution as seen here, because this is hematogenous dissemination of the disease. And since there is more blood flow at the lung bases than in the lung apices, we can expect to see more disease at the lung base. Biliary tuberculosis or hematogenous tuberculosis is actually kind of interesting radiographically. It can present as a more subtle finding, again as shown here, although at least you can see it. Remember that sometimes what you actually see in these patients is they come in, they're quite ill, they seem septic. The first chest film you see may actually look normal. A day or two later, you start to see a pattern that looks like this, and this is, again, miliary tuberculosis. Blow that up a little bit. You'll see these very similar sized nodular opacities scattered throughout the lung in a uniform distribution. And if you look at CT on this, again, you get these small nodules throughout the lung. This is miliary TB. Now, the one problem with saying miliary is, my experience has been that, particularly with residents, if they describe the pattern as miliary, the only thing they can ever think of after that is tuberculosis. Okay, miliary equals tuberculosis in their mind. So it's easier sometimes if you say small nodular opacities, because that at least leaves it open to you that other things can cause a pattern that looks very similar. So here's a case in which you can see these small nodules, just like the miliary TB case we were looking at. But this is, in fact, metastatic carcinoma. And you should keep in mind that there are a couple of malignancies that can produce a pattern radiographically that looks very similar to miliary TB. And the two most likely to do it, in our experience, have been carcinoma of the thyroid and metastatic melanoma. This particular case that you're looking at is actually metastatic melanoma. But I would guarantee, and having shown it to a lot of residents, I can tell you that most often when they see it, the thing they think about is miliary TB, which is a reasonable thing to think about. But what is missing is they can't go on because they've sort of said miliary and then they stop. So small nodular opacities, remember metastatic disease, and keep in mind particularly thyroid and malignant melanoma. Okay, next case. Now we're looking at a case in which, again, we see a diffuse reticular pattern, a reticular nodular pattern. Actually, the nodule may be more apparent to you here. But notice as you look at this, that there's, again, a tendency toward an upper lobe predominance of this disease. And an upper lobe predominance is particularly helpful because there aren't as many diseases that do that. We've talked about tuberculosis, and this is the pneumoconiosis, and silicosis in this case. And by and large, because these dust particles are very light, they tend to be drawn to the upper lung zones, and the earliest evidence of the disease is in the upper lung zone, and the predominance generally is in the upper lung zones for most of the pneumoconioses, with the exception of asbestos. Asbestos differs because that fiber is long and heavy, and it tends to go toward the lung base. All the others tend to go toward the upper lung zone. One variant to keep in mind, it's very striking, and you should always recognize it if you see it, of the pneumoconiosis and cold workers of silicosis, are these progressive massive fibrotic areas, progressive massive fibrosis, conglomerate disease, generally in the upper lung zones. They tend to contract together so that distal to them you will see changes that look like emphysema with linear stranding as shown in this case. So this is basically silicosis with progressive massive fibrosis. You should remember, whenever you see sort of kidneys in the chest in the upper lung zone, think silicosis, progressive massive fibrosis. Now I mentioned that the exception in the pneumoconiosis to that upper lobe distribution is asbestos. And again, because the fibers tend to go toward the lower lung zone and often create changes at the lung bases. Now this is the ranking classic of asbestos exposure, and that is calcification over the hemidiaphragms and the pericardium, as shown here. If you only see calcification on the hemidiaphragms and the pericardium, what you can say is that this patient has been exposed to asbestos. To talk about asbestosis, legally, that really means that they have underlying lung disease. So you have to see definite evidence of underlying lung disease, which actually we do see here. Now this is the ranking classic, but I will tell you that it is the least common radiographic manifestation of asbestos exposure. The most common manifestation is actually, if you were asked, what is the most common radiographic abnormality we see if the patient's been exposed to asbestos? The answer to that is a small pleural effusion. Unfortunately, or fortunately, small pleural effusions are so non-specific that we usually don't talk about that. The next most common thing to see is shown here, which are pleural plaques without calcification. And again, you can tend to see these things along the pleura, usually in the mid and lower lung zones, as shown here. You can see them very well. These are pleural plaques, and they are caused because the asbestos fiber actually pokes through the visceral pleura. And as one breathes, it scratches on the parietal pleura. So that's where these things are actually occurring. And they're in the periphery of the lungs, in the mid and lower lung zone. So this would be sort of the next most common. It's not quite as classic as the calcifications that we talked about, but it's certainly more suggestive than a small pleural effusion. All right, moving along, we should all recognize this, and here in the South we see quite a bit of this. This is sarcoidosis in its stage 1 form, characterized by generally symmetrical, although this is a little asymmetrical, hilar involvement of both lymph node involvement of both hilar and the paratracheal nodes as well, reflecting mediastinal involvement. But as this disease progresses, it moves from this to this. Again, a reticular nodular pattern throughout the lungs, often with a little bit of sparing at the apices, as shown here, and sometimes at the base. So it kind of involves the whole lung with a little sparing at the apices and at the base. Reticular throughout. And the interesting thing is, as the interstitial pattern progresses, the hilar adenopathy, which is so classic in stage 1, seems to recede. Now, whether it actually gets smaller, it's just visually less prominent, is not entirely clear. But it will look to you, as you look at the film, that it is less prominent than it was in that early stage. But if you look carefully, you can still see that these hilar are enlarged, and there's some mediastinal, right paratracheal adenopathy as well. Interestingly enough, and I should have mentioned this earlier, in sarcoid and in TB, even though they're interstitial lung diseases, you very rarely see septal lines. You don't see them in that disease. We see them commonly in congestive heart failure, and I'll point out some other places we see them. But you don't tend to see them with tuberculosis. You don't see them with sarcoidosis. And keep in mind that as the disease progresses into its fibrotic stage, and here we see upward retraction of both hilar and this upper lobe distribution, this looks very similar to tuberculosis. And actually, for many years here in the South, where we had a lot more sarcoid than we have TB, when we saw this kind of upper lobe fibrosis, it was much more likely to be secondary to sarcoid than it was to TB. With the outbreak of the AIDS epidemic, when we started seeing more TB again, it's a little harder to be sure whether you're looking at TB or end-stage sarcoid. Both of them look radiographically identical. All right, I want to turn now to just a brief discussion of drug-induced pulmonary diseases. There's a whole variety of them, as you know. Generally, you can think about them in 2 classes. Think about all of the cytotoxic drugs, some of which are listed here, and then the non-cytotoxic drugs as shown here. The big group are the cytotoxic drugs, and then there's a whole group of these non-cytotoxic drugs as illustrated here, and I think they're in your book for you. Now, just keep in mind that drug reactions can manifest themselves as interstitial lung disease. And here is an example, in this case, methotrexate lung, the diffuse reticular nodular pattern, very prominent septal lines as seen in this case. Again, really, I think reflecting an underlying edema. But again, when you see prominent septal lines, keep in mind, we talked about interstitial pulmonary edema. Also, methotrexate or drug-related things do that. Okay, now we'll turn toward the basilar distribution, and I've enhanced this a little bit. That's why it looks so dark up here. But this basilar, bibasilar, symmetrical, reticular nodular pattern shown here. Again, you can see sort of a mix of reticular and nodular. This is UIP. And again, basilar distribution, patchy at the periphery, scattered throughout the lung, but often in a peripheral patchy nature. This is UIP as commonly seen. Here's another one. Basilar distribution as you look at it. Fine interstitial lung disease. As you look, you can see it's much more prevalent at the lung base than at the lung apex. Now, of course, there's more lung down here. So most diseases are actually at the lung base, except those few we talked about earlier. There's actually a clue on this film as to the correct diagnosis. Look up here. Here's the tracheal air column. Then notice running right next to it, right here, is another column of air. That's air in the esophagus. And while it's not unusual to see a little bit of air in the esophagus, to see it over a distance from here to here should tell you that there's a problem with esophageal motility, as illustrated here. And this is scleroderma. So right back up. Here is a case, basilar disease, collagen vascular type disease, and this is scleroderma. Okay, let me looks like. It's a little out of focus how it looks to you. But again, diffuse interstitial lung disease, we'll look at this lung base in just a moment, associated with hilar adenopathy and often effusions. You can see some septal lines running along here. This is another disease that causes lots of septal lines. This is so-called lymphangitic spread of tumor. What should you know about lymphangitic spread of tumor? Well, first of all, you can see it with adenopathy and with pleural effusion. It's a pretty easy diagnosis. I will again tell you that quite often in lymphangitic spread of tumor, you see very prominent septal lines. So this is another one with good septal lines. Lymphangitic spread of tumor is actually a bit of a misnomer. Most of these diseases are not actually spread lymphangitically, they're spread hematogenously. It can occur that if you block the lymphatics, that you will get a pattern that looks like lymphangitic spread. But most commonly, pathophysiologically, it is a hematogenous dissemination of the tumor emboli to the distal parts of the lungs and antegrade growth through the lymphatics. The other thing to know about lymphangitic tumor is that it's almost always an adenocarcinoma. If you see that, you almost always know it's an adenocarcinoma, and I like to think that the four most common sources for that adenocarcinoma are actually shown to you on the chest film, and they are breast, lung, stomach, and pancreas. Right? So breast, lung, stomach, pancreas are the ones that will do it most commonly, but it will almost always be an adenocarcinoma. Now there's one sort of Röntgen classic that you should be familiar with, because if you see it, you can virtually make the diagnosis, and that is unilateral interstitial lung disease. Again, notice in this particular case, particular nodular pattern throughout the right lung, very prominent septal lines. The left lung is actually pretty normal. So it looks like unilateral interstitial lung disease. And in my experience, if you see unilateral interstitial lung disease, you can virtually make a diagnosis of lymphangitic spread of tumor, adenocarcinoma. Now, what you'll see, it usually works out in these cases, they normally can't really find the primary. I tend to believe most often it's going to be a lung, and that what's really happening, and it's more common on the right, what really happens is the lymph nodes get obstructed centrally by a central adenocarcinoma, and it creates congestion in the lymphatics on one side, which thickens all the interlobular septa. See it again, they almost always have very prominent septal lines and small pleural effusions, as shown in this case. But again, adenocarcinoma, lymphangitic spread, likely primary lung. It's almost pathognomonic. Here's a CT showing this nodular sort of interstitial septa, interlobular septa. And on the pathology, you can see the same kind of thing. This lobulated interlobular septa, and that's what's giving us the radiographic pattern. But if you see it unilaterally, it really makes it very easy. Okay, next case, again, reticular nodular pattern throughout both lungs. One thing that I didn't point out to you as we were going along, and probably should have, is that by and large, when you have interstitial lung disease, it reduces lung compliance. So the lungs the volume is smaller. This is a case with diffuse interstitial lung disease and large lung volumes. These are pretty good lung volumes. That's a smaller and easier handled differential. In this particular case, we are looking at a case of eosinophilic granuloma. But what I want you to recognize is when you see diffuse interstitial lung disease and large lung volumes, the differential changes just a little bit, and should include cystic fibrosis, angiomatosis, eosinophilic granuloma, and diseases that are superimposed on underlying large lung volumes, that is, emphysema. Okay, here's again a case of diffuse interstitial lung disease, reticular nodular pattern throughout the lungs. On the lateral, you can see these huge lung volumes and some prominence of the central hilar areas, reflecting both adenopathy and pulmonary arterial hypertension. But interstitial lung disease, large lung volumes, this turns out to be cystic fibrosis. It's another similar case. Large lung volumes, reticular nodular pattern. In this case, the cystic component of the disease is a little more prominent. You can see that very well. All right. now we begin to move into diseases that should be known to all radiologists, although are not as widely known to others practicing medicine. And in front of you is a disease that's endemic probably in Louisville. Seem to encounter it not infrequently there. Although I would tell you that if you're not in Louisville and you miss every one of these that you ever see, you won't have missed that many cases. But you should know it if you happen to be passing through Louisville. So it comes up. This is lymphangiomyomatosis. Diffuse reticular pattern throughout the lungs. Large lung volumes, as we see here, particularly on this side. But also associated with pneumothorax and pleural effusion. And of course, as you know, in lymphangiomyomatosis, a disease occurring only in women, generally premenopausal. They suffer also from recurrent pneumothoraces and recurrent pleural effusions. And the final little point is that the nature of these pleural effusions is that they are chylous. Right? So recurrent chylous pleural effusions, recurrent pneumothoraces, large lung volumes, interstitial lung disease, generally young women, lymphangiomyomatosis. Where it gets a little tricky is that the other disease that could look almost like this is granuloma. Can occur obviously in young patients, in women. Interstitial lung disease, it is given to recurrent pneumothoraces, but eosinophilic granuloma is not associated with significant pleural effusions. So in this case, you look at it and say, diffuse interstitial lung disease, large lung volumes, recurrent pneumothorax, should be EG versus LAM, no pleural effusions, favor EG, favor strongly EG, probably not lymphangiomyomatosis. So there's the contrast. Looking at this case, interstitial lung disease, recurrent pneumothoraces, large pleural effusion, think LAM, no pleural effusion, think EG. Now, of course, that would be the easy one. The harder one and the real-life situation is this, where you have basically a young woman, diffuse interstitial lung disease, large lung volumes, no pneumothorax, no pleural effusion. Is it EG or LAM? And unfortunately, I'm forced to admit that on the plain film, you really can't tell. They both look virtually identical. On the CT, however, you can easily tell because it tends to have thick-walled cystic changes. LAM has thin-walled cystic changes. So this is one of those places where CT really does make a difference. Makes it very easy to see, even though radiographically on the plain film it's impossible. Now, all of these diseases, if they hang around long enough, will create what we refer to as end-stage lung. An end-stage lung is like any other end-stage organ. When you get to that point, it's pretty hard to tell what started the process. But if you're looking at an end-stage lung, think about eosinophilic granuloma, interstitial fibrosis, UIP, IPF, sarcoidosis, and the pneumoconiosis. These are the ones most likely to persist over a long period of time and end up scarring the lung and creating an end-stage lung. End-stage lung, often referred to as a honeycomb lung, same thing. Why is it called that? Because it looks like this pathologically. You look at it, now whether this would look like a honeycomb to a bee or not, it's a little bit up in the air, but to us, it's said to be like a honeycomb. It has these multiple cystic areas, generally thick-walled, of varying sizes, scattered throughout the lung. Essentially, the organ is destroyed. It's an end-stage organ. Not that much different than end-stage liver, end-stage kidney when you see it. Hard to know where it started. But the common causes, as we said, include eosinophilic granuloma, sarcoid, and pneumoconiosis. This one, which you see, again, large, thick-walled, cystic areas throughout both lungs. This is end-stage lung. Hard to know where it started. Historically, it turns out this is eosinophilic granuloma. Show that to you close up again. You can just about visualize that gross path specimen I showed you to this, how you get these multiple cystic areas of varying sizes with thick walls, complete distortion of the normal underlying architecture. So, in summary, I want you to keep in mind this particular differential if you encounter a case of interstitial lung disease, reticular, nodular, small nodular. Think first is interstitial pulmonary edema. Then TB and the pneumoconiosis if it has an upper lobe predominance. sarcoid and PCP if it's diffused throughout the lungs, interstitial fibrosis for all these categories, and lymphangitic tumor if it's lower lung, and if it's none of the above, think eosinophilic granuloma. If you see interstitial lung disease and large lung volumes, think of these four things: cystic fibrosis, lymphangiomyomatosis, eosinophilic granuloma, and other interstitial lung disease superimposed on underlying emphysema. And if you're dealing with a totally distorted, end-stage honeycomb lung, think of these things: eosinophilic granuloma, interstitial fibrosis, sarcoid, and the pneumoconiosis. If you look at this, actually, this particular differential is pretty similar to the first differential of interstitial lung disease. It's just the ones that last chronically, and you read from the bottom up. So eosinophilic granuloma, interstitial fibrosis, sarcoid, and then pneumoconiosis. So you really don't have to memorize one and learn to read top down and bottom up. Okay, so we're going to stop on that. If you keep those things in mind, I think you'll be able to deal with any case of interstitial lung disease that you see. And it should help you through from the plain film now to a discussion of high-res CT. And Dr. Paige McAdams, a professor in our division of cardiothoracic imaging, is presenting. Let me say one last thing to you about this course. You're going to be hearing lots and lots of talks this week. There are more than 80. It can be a bit overwhelming. What I recommend you try to do is just look for 2 or 3 points in every talk that is either new or you haven't thought about for a while. Write those down. The rest of the stuff you'll probably know. But if you pick up 2, 3, 4 points out of every talk, you'll be way ahead by the end of this week, and it'll actually feel like a manageable experience. Okay, good luck. We hope you enjoy the course, and we'll see you tonight at dinner. You'll enjoy it. Thank you very much. Good morning. Let me see. Okay, Dr. Raven's just given you an elegant introduction to evaluation of interstitial lung diseases on the plain film. And suffice it to say that we know that obviously the plain film is integral for both detection and differential diagnosis, but high-resolution CT obviously has become really the mainstay for evaluation of suspected interstitial lung diseases, and certainly is viewed as such by our clinical colleagues. What I want to do in the next 30 minutes is review some of the basic features of interstitial lung diseases that we will detect on high-resolution CT and the differential diagnosis thereof, and give you an approach to interpreting these scans. And we'll be going relatively rapidly. All this material is in your handout, and I'll be available after the talk for questions. Now, I think the best way to look at a high-resolution CT scan is to divide the primary features of ILD into 6 categories: septal thickening, irregular lines, air-filled cysts, nodules, ground glass opacities, and consolidations. And we look at the high-resolution CTs, and I look specifically for these 6 features, and I will base my differential diagnosis upon the presence or absence of these individual features. Now, there are secondary features which are of help as well, and that includes distribution of disease. That's of particular importance. Evidence of fibrosis, architectural distortion, traction bronchiectasis, that can be a help in differentiating between various causes of ILD. Presence or absence of air trapping, pleural disease, and lymphadenopathy, of course, are important ancillary features that may suggest one particular diagnosis. In the case of lymphadenopathy, we might think of sarcoid. Pleural disease, specifically pleural plaques, we might think of asbestos-related lung disease. Now, before we get started, I want to emphasize distribution a little bit more strongly, because that is really a critical and key component of constructing a differential diagnosis of ILD based on high-resolution CT scans. We can conceptualize the interstitium not as a single uniform compartment, but actually as composed of 3 individual compartments, which were labeled by Dr. Weibel as the axial interstitium, the peripheral interstitium, and the septal interstitium. These are 3 distinct compartments, but they interlock to form the entire connective tissue network of the lung. And really the important points are distribution. Diseases may distribute along this axial interstitium. This is the connective tissue bundle which invests the bronchiovascular bundles as they leave the hyla and enter the lung and then ramify out distally.
Diseases that preferentially involve the axial interstitial compartment on high-resolution CT include sarcoidosis, lymphangitic carcinomatosis, and a variety of airway-centered processes such as bronchiolitis. On the other hand, we may identify diseases which preferentially involve the peripheral aspect of the interstitium or the peripheral aspect of the lung. And when we can identify that as a dominant feature on high-resolution CT, we're typically talking about the fibrosing disorders of lungs such as UIP, NSIP, for instance, asbestosis, and occasionally pulmonary edema. And we do occasionally scan patients with pulmonary edema, so it's worthwhile knowing the CT features thereof. And then there are a group of course diseases which may affect the lung in a more diffuse fashion. It may affect the central portions of the lung, it may affect the peripheral portions of the interstitium, it may affect it relatively diffusely, and we can discern no particular distribution on the CT scan. And these include things like metastatic disease when it manifests with lymphangitic carcinomatosis on occasion, lymphangioliomyomatosis, Langerhans cell histiocytosis, or eosinophil granuloma of lung, and then some of the pneumoconiosis, silicosis, and coworkers. Now, some of these, particularly the bottom three, will predominantly involve the upper portions of the lung, but on an axial slice, it's often difficult to distinguish a central or axial versus a peripheral gradient of disease. The other key feature of distribution to note relates to the lobular anatomy. Now, you should be familiar with the secondary pulmonary lobule. This is the basic unit of lung structure that we identify on high-resolution CT. It is composed of the interlobular septum, which divides one lobule from another. There will be a lobular bronchiole and artery, that sort of thing, remembering that the pulmonary veins run in the septa, as do lymphatics. Lymphatics run both along the bronchovascular bundles and within the septa. And on high-resolution CT, we can often distinguish that processes are distinctly centralobular in distribution, that is, occurring along this core lobular bronchiole and artery. And when we can identify that as a predominant feature of distribution, we're primarily talking about either airway-centered diseases such as extrinsic allergic alveolitis, various forms of bronchiolitis, or infection. Okay, let's look at some of the primary features. What do we think of this case? This is a cone-down view of the left upper lung. You can see very distinct and marked thickening of intralobular septa. See right here, here, here. And that's actually the primary and dominant feature in this particular case. Now, when septal thickening is the predominant abnormality on high-resolution CT, the differential diagnosis is relatively limited. We're primarily talking about either pulmonary edema or lymphangitic carcinomatosis. Uncommonly, we will see sarcoid manifesting with a fair amount of septal thickening and certain cases of disseminated infection such as miliary tuberculosis. That's relatively uncommon. Most of the time when septal thickening is the predominant abnormality, we're going to be talking about lymphangitic nets or pulmonary edema. Now, this particular case, this is an obvious example of lymphangitic carcinomatosis, and the reason is that not only are the septa thickened, but they are nodular. When you see nodular thickening of the septa, most of the time you're going to be dealing with lymphangitic carcinomatosis. Notice also that we don't have much in the way of a gravity-dependent distribution of septal thickening. The septa are just as prominent anteriorly as they are posteriorly. Contrast that to a patient who had pulmonary edema and got scanned, and we can see thickening of the septa is a predominant feature, but notice that these septa are relatively thin. They are not beaded nor nodular. There is some central ground glass opacity representing edema in the air spaces. But notice also this gravity-dependent distribution of septal thickening. There's a relative absence of thickening anteriorly. They're markedly thickened posteriorly, and of course that's because the pulmonary venous pressures in the posterior lung are greater than those in the anterior lung. So pulmonary edema. Now, this patient has a different pattern on high-resolution CT. In this case, the predominant pattern are these irregular areas of linear opacity. Now, in this area, it's become more conglomerate. We may actually identify some fibrosis here as evidenced by traction bronchiectasis, a little conglomerate fibrosis. We see all these irregular areas of linear opacity, which are not discretely thickening or not discrete thickening of interlobular septa. There are also a few scattered nodules. Notice also that the distribution here favors the central or axial component of the interstitium. It's clustered along bronchivascular bundles, as you see here. In this case, this is a case of sarcoidosis. And when I see irregular lines in a perihilar, peribronchovascular distribution, typically mid and upper lung zones of lung, the most likely diagnosis is going to be sarcoidosis. Again, we can think of sarcoid as beginning in the hilar mediastinal lymph nodes and then climbing into the lung along the lymphatics and invest those bronchovascular bundles and ramifying distally throughout the lung. But in most cases, it will retain that central pattern of involvement, whether you see it in nodular form or in this case with a more reticular abnormality. Here's another case of sarcoid. Again, irregular lines is a primary manifestation, a few scattered lung nodules, but again, notice the distribution and the clustering in the axial or central connective tissue compartment, which is very typical of sarcoidosis. Here's another patient with sarcoid, an ancillary feature, of course, suggestive of the diagnosis, massive, in this case, calcified lymphadenopathy. And when the process becomes very severe, we may see conglomerate areas of fibrosis, which is fairly typical in a posterolateral perihilar distribution. We may see central air bronchograms with many areas of conglomerate abnormality, other irregular areas of linear abnormality as well, very typical of end-stage sarcoidosis. Here's another patient with where the predominant finding here are irregular lines. You can see them here. Some of these are thickened interlobular septa. The predominants are thickened intralobular septa. Again here. But notice, as opposed to the patient with sarcoid, the distribution here is predominantly subpleural, involving that peripheral connective tissue compartment. There is some involvement centrally at the bases, as evidenced by traction bronchiectasis, but the predominant abnormality, particularly in the less involved areas of lung, in the subpleural regions of lung. When you see irregular lines in a subpleural distribution, mid and lower lobe typically, you're primarily dealing with the fibrosing disorders of lung, of which idiopathic fibrosis, or UIP, will be the most common. This may be also a case of fibrosis related to asbestos inhalation, asbestosis. It may be fibrosis related to collagen vascular disorders, pulmonary drug toxicity, or even occasionally chronic hypersensitivity pneumonitis. But you know that this is going to be one of the progressive fibrosing disorders of lung. Now, asbestosis, just by way of comment, often begins with linear band-like opacities in the subpleural regions of lung, as you can see here. In very early form, it may be difficult to distinguish these abnormalities from dependent atelectasis, and that's why prone imaging is really mandatory if you're looking for early findings of asbestosis. You can see that these findings persist, subpleural irregular lines, right, independent portions of lung, but notice that they persist on prone imaging, so these are real findings not related to dependent atelectasis. In this case, the associated finding of pleural plaques, some of which are calcified, would suggest the correct diagnosis. Moving forward to air-filled cysts, this patient obviously has a lung parenchyma full of thin-walled, air-filled cysts. Here, really innumerable cysts scattered throughout the lung parenchyma. Now, when we see air-filled cysts on high-resolution CT, there are really a few things that we should think about. One would be the so-called cystic lung diseases, of which lymphangiomyomatosis and Langerhans cell histiocytosis are the best known. We may also see air-filled cysts in patients with Sjogren's syndrome and LIP. That's relatively rare. We may see air-filled cysts in some patients with infection, notably pneumocystis pneumonia. We may see air-filled cysts in patients with honeycomb fibrosis. And we may see what looks like air-filled cysts in patients with a variety of other processes that mimic cystic lung disease, notably bronchiectasis and emphysema. Lymphangiomyomatosis, as Dr. Raven pointed out earlier, tends to manifest with relatively thin-walled cysts. You can usually perceive no significant distribution, axial or central, top and bottom throughout the lung. There are usually no other associated findings other than the cysts. You may see pleural fluid, of course, which may be chylous in nature. It's a patient with cystic lung disease, but these cysts look different from those of patients with lymphangiomyomatosis. These are larger. They're more irregular. They're coalescent into these somewhat linear or tubular shapes, as you see here. And these cysts are typical of Langerhans cell histiocytosis or eosinophilic granuloma oblong. Now, the variety of lesions that you may see in patients with LCH include irregular cysts, which may be either thin or thick-walled. You may see nodules, which are typically central-lobular distribution, and you may see cavitated nodules in the same patient. Distribution is relatively homogeneous, axial to peripheral, but this disease tends to involve the upper lobes of lung, as you know, and the vast majority of these patients are smokers. That's right. The vast majority of these patients are smokers, and this is considered a smoking-related lung disease. Here's another patient with LCH. In this case, we see smaller cavitary nodules. We see some scattered central-lobular nodules, and some other areas of less well-formed cystic change within the lung. It is the finding of nodules and clear-cut air-filled cysts which allows us to make with high confidence a diagnosis of Langerhans cell histiocytosis on CT. Another patient with cysts, notice that these cysts are somewhat more thick-walled, a little bit more irregular. But there is also the finding of scattered areas of ground glass opacity. Now, ground glass opacity is not a typical feature of either EG or lymphangiomyomatosis. So the combination of ground glass opacity and scattered air-filled cysts suggests what diagnosis? That's right, pneumocystis pneumonia. On occasion, we will scan patients who turn out to have pneumocystis pneumonia. They may not have or have been diagnosed as having HIV disease. They simply present with progressive dyspnea. We scan them, and we may see thin-walled air-filled cysts and scattered areas of ground glass opacity. Pneumocystis pneumonia, this is I thought I got this out of here, you may know. It is no longer pneumocystis carinii. It has now been renamed pneumocystis jirovecii. So most people just refer to it as pneumocystis pneumonia to eliminate the pronunciation difficulties. Another patient with air-filled cyst on high-resolution CT. Notice that these cysts cascade one on top of another. They're variable in size. They're variable in wall thickness. And in this portion of lung, at least, they are distinctly subpleural in distribution. What is this an example of? Okay. This is honeycomb lung. Right? This is honeycombing. And we should be pretty confident in differentiating honeycomb fibrosis from other forms of quote-unquote cystic lung disease, such as EG or LAM. Now, in this particular case, this is honeycombing due to scleroderma. Maybe difficult to see, but there's a little dilated esophagus right there. The key features of honeycombing, again, are variable-sized cysts. They are typically peripheral in distribution. They cascade one on top of another, as you see here. There are usually multiple layers of cysts, between 2, 7, 10 layers on occasion. And this, of course, is the end-stage process of those diseases we discussed earlier, the progressive fibrosing disorders of lungs, such as UIP, idiopathic pulmonary fibrosis, end-stage asbestosis or drug toxicity, end-stage lung, oncology vascular disease with associated pulmonary fibrosis, in this case with the dilated esophagus in a patient with scleroderma. Now let's look at this for just a second. This patient also looks like they have cysts, scattered throughout. But if we begin to look at this case fairly carefully, we would notice that the vast majority of these low attenuation areas do not have a discernible wall. These are more like punched-out lesions, very much as you would describe a punched-out lesion in a patient with myeloma, an area of lucency, without a well-defined wall. And this, of course, is an example of central lobular emphysema. It's very important that we differentiate emphysema from some of the cystic lung diseases because emphysema will be over 100 times more common than the variety of cystic diseases we've just discussed. And you will encounter many, many, many cases of emphysema in your practice to maybe 1 or 2 cases of EG or LAM in your practice. Central lobular emphysema begins as little punched-out lesions along the core lobular artery and bronchus. And when we see it like this, it's really not that big a deal. It's pretty clear-cut emphysema. The problem is you'll occasionally see cases of very advanced disease, as you see in this particular example. And with very advanced disease, you can also get a fair amount of fibrosis in the interlobulous septa. So you get thickened septal walls, diffuse emphysema within the secondary lobule there, and it looks very much like a cystic lung disease. This looks like maybe end-stage EG or something like that until you look at it very carefully. Now, one of the characteristics of very severe centrolobular emphysema is even though the entire lobule may be involved in the septa thickened, it still retains that polygonal shape of the secondary pulmonary lobule. Notice that the walls of these lesions are by and large relatively straight or in pentagons or hexagons. The second feature is that the core lobular artery will often be preserved until very late in the disease course, and so we will see central dots within the areas of emphysema. So if the cyst that you're looking at on CT is polygonal in shape and has a central dot, that is severe centrolobular emphysema. It's not LAM or EG. By way of contrast, our patient with EG, notice again that the cyst walls are rounded in shape, and because these are space-occupying lesions, they tend to displace the core lobular artery to the periphery of the cyst. So we don't see any central dots within these air-filled cysts. They're all at the periphery. They're regular in shape. They have rounded contours. This is a cystic lung disease. These are very irregular, variable in shape. We would favor histiocytosis X, EG, etc. in this particular case. Another mimic on a single image. This looks like a cyst. It's fairly well defined. There's a peripheral vessel here. It looks like that peripheral dot sign. But if we look on lower images, we can identify the fact that this represents very severe bronchiectasis. And we can't be fooled if we look at a single slice into mistaking bronchiectasis with cystic lung disease. That's why it's important to look at the entire study as you go through. Make sure that you're not looking at dilated bronchi rather than true air-filled cysts. Diagnosis here? What's the cause? Notice the dilated central airway. Markedly dilated trachea, dilated main bronchi, William. Okay. All right, we'll move on to the pattern of nodular opacities. The predominant abnormality in this case are nodules, as you can see here. Notice that these nodules are not randomly distributed, but they are ramifying along that central connective tissue compartment, as you see here and here, ramifying throughout the lung. Notice that in this case we have some distributed along the fissure as well. When I see nodules on CT, I find it helpful to try to break up their break up the differential diagnosis by appearance and distribution. And in those nodules that tend to cluster along bronchovascular bundles, those that occur within the center of the secondary lobule, central lobular nodules, which may be either a solid or ground glass attenuation, and my differential is a little bit different depending upon which it is, and then nodules that occur diffusely throughout the lung. In this case, we have a very distinctly bronchovascular bundle distribution. Okay, when we see nodules in that distribution, we're primarily talking about sarcoid. I've seen a few cases of lymphangitic carcinomatosis manifest in that fashion, but certainly this distribution, particularly with the nodules along the fissure, along pleural surfaces, suggests a diagnosis of sarcoidosis. Here's a patient with a different distribution. We can see some clustered nodules down here very clearly in the center of the secondary pulmonary lobule. These are solid central lobular nodules. In some areas we may also see some linear opacities, rendering these as tree in bud opacities, but the primary finding here is central lobular solid nodules. When we see nodules in the center of the secondary lobule, we're primarily talking about infectious processes, tuberculosis, probably a little bit more commonly non-tuberculous mycobacterial infection. There are a variety of forms of bronchiolitis, and occasionally Langerhans cell histiocytosis, but as I mentioned, we like to see cysts or at least cavities within the nodules to suggest a particular diagnosis. This patient had interbronchial spread of tuberculosis. This patient with Langerhans cell histiocytosis with a purely nodular form. Now, there's no way on this CT that we're going to come down hard on EG as a diagnosis here. We may include in the differential diagnosis. There's a relative paucity of nodules, but the ones that we see are predominantly in the center of the secondary pulmonary lobule. They are solid. We have a differential here, again, intobronchial spread of infection, Brightus, bronchiolitis, Langerhans cell histiocytosis, and a biopsy. This patient had EG. This is a different appearance, though, and a fairly distinctive one. Here we have ground glass nodules in the center of the secondary lobule. I think you can see it best right up here. This is a secondary lobule. You can identify it by its polygonal shape. The septa are not thickened, but within the center of that lobule, we have this puff of smoke, or ground glass nodule. We see some other ones, perhaps a little bit more involvement of the lobule here. Perhaps the entire lobule is involved here, but out here peripherally, you can see very nicely these central lobular areas of ground glass opacity. This is a very typical appearance for extrinsic allergic alveolitis or hypersensitivity pneumonitis. And when we see this pattern on CT, that's the first thing on our differential. Now, there are other things, some forms of respiratory bronchiolitis, some infectious bronchiolitis, viral infections, and that sort of thing may be considered. I'll show you a case of tumor that looks very much like this as well. But most of the time in someone with a progressive pulmonary disorder, suspected interstitial lung disease, this pattern will be due to extrinsic allergic alveolitis, things such as Birdfangier's lung or Farmer's lung, and a variety of other forms. That was EAA. Here's another case of EAA. In this case, the nodules are perhaps slightly more well-defined. They're still predominantly of ground glass attenuation. They're still predominantly within the center of the secondary pulmonary lobules. Yes, this could be a very severe form of respiratory bronchiolitis. It could be something infectious. But our first differential possibility should be EAA. Now, this case on first glance looks fairly similar. We see some ground glass nodules. Some of them are a little bit larger. That might be involving the entire lobule. Like here, they look distinctly central lobular distribution. We might be thinking about EAA, bronchiolitis, and that sort of thing. And this patient actually turned out to have endobronchially disseminated bronchoalveolar cell carcinoma. So I'll throw that out to simply point out that everything has a differential diagnosis, so you may want to keep that in the back of your mind, particularly if we don't have such a fairly homogeneous distribution of disease. The final pattern of nodularity is demonstrated in this case. Diffuse, tiny nodules, randomly distributed. They don't demonstrate a predominantly axial or peripheral distribution. Some are centrolobular, but they are relatively diffuse and homogeneous across the axial cross-section. And in this case, I'm thinking about things like disseminated infection, miliary tuberculosis, for instance, occasionally Langerhans cell histiocytosis, the inhalational disorders of lungs such as silicosis or co-workers pneumoconiosis, metastatic disease, and occasionally sarcoidosis. Even though we typically think of sarcoid as spreading along those bronchovascular bundles, occasionally, because it is a common disease, we'll encounter it in more of a diffuse fashion. In this case, the patient had miliary tuberculosis. The sarcoid that we saw recently, relatively diffusely distributed tiny nodules. It's hard to discern much of a bronchovascular distribution. Here there is some involvement along the pleural and subpleural regions of lung, but relatively diffuse in distribution. And this was sarcoid, again, a fairly common disease, and uncommon manifestation of common diseases turn out to be relatively common. So remember to include sarcoid even if the nodularity is more diffuse. Moving on to ground glass opacity. These findings, of course, as you know, are much less specific. We have these scattered areas of ground glass. We have a little bit of subpleural sparing. Ground glass opacity, as you know, is defined as an area of increased attenuation within the lung that does not obscure the underlying lung architecture, particularly the underlying lung vessels. Now, the differential for pure ground glass opacity is very long. It's very difficult on a CT scan without a lot of other clinical history ancillary findings to narrow it much. It's useful to have in mind a few causes: edema, drug toxicity, alveolar prognosis, hemorrhage, etc., but realizing that this is a very nonspecific differential diagnosis. This turned out to be a case of edema. However, when you see this pattern of ground glass with these superimposed reticular opacities, and then scattered areas have been interspersed lung, that becomes perhaps a little bit more specific. And this is known as the crazy paving pattern. Again, it would be defined as areas of geographic ground glass opacity with superimposed areas of thickening of both inter- and intralobular septa with interspersed areas of normal lung. This is my basic differential for crazy paving. It has been described in other conditions. I would probably add drug toxicity to this list, because we've recently seen a number of cases of drug toxicity with this pattern on high-resolution CT. So I would include 4 things, really: alveolar prognosis, alveolar cell carcinoma, lipid pneumonias, and then drug toxicity is my top 4 in the differential for this appearance on CT, and then you sort those out, of course, depending upon the clinical scenario. This was a case of alveolar prognosis. At first glance, this patient looks like they have ground glass opacity, geographic. Notice it's relatively central in distribution. Notice, however, the marked disparity in size of lung vessels between the hyperattenuating and the hypoattenuating areas of lung. That is a clue that you're not dealing with ground glass opacity in the sense of an infiltrated lung disease, but that you're dealing with the phenomena related to differences in lung perfusion, or so-called mosaic perfusion pattern. The differential diagnosis for a mosaic perfusion pattern is relatively limited. You're primarily dealing with a vascular disease, occlusive vascular disease in the pulmonary circulation, or occlusive small airways disease, or obliterative bronchiolitis. Now, when the cause is vascular, we will typically see 2 things. One, the areas of differential attenuation will be quite marked and usually quite obvious on inspiratory high-res CT scans. Secondly, the disparity in vessel size will typically be quite marked and quite obvious, as in this particular case. So very obvious differences in lung attenuation, very obvious differences in size of vessels, suggests a vascular etiology, usually going to be chronic pulmonary embolism. The other feature, of course, if we had an expiratory study, we would see an absence of air trapping in that setting. Here is a contrast-enhanced scan through the hyla demonstrating, of course, typical features of chronic PE, peripheral clots, clot in the right atrial appendage, etc. Now, in patients that have constrictive bronchiolitis manifesting with this mosaic attenuation pattern, usually on the inspiratory exam, the findings are quite subtle, and I'm not sure how well it projects, but there are alternating areas of high and low attenuation, this being higher, this being lower. Notice that the difference in vessel size here is not very obvious. It may be very difficult to appreciate, first, if there's any difference in lung attenuation at all, and that there's any difference in size of vessels. But on the expiratory exam, of course, the disparity in lung attenuation becomes very marked, quite obvious as in this particular case, indicating that this is due to small airways obstruction. This patient had bronchiolitis obliterans as a manifestation of chronic graft versus host disease. The final pattern that we will occasionally encounter in some of the patients thought to have an infiltrative or interstitial, and I'll use that as a closed lung disease, will be areas of consolidation, which is defined as a homogeneous opacity that obscures the underlying lung vessels. We may see an air bronchogram sign, as we see here in this patient who had undergone lung transplantation and had progressive dyspnea and abnormalities on the chest radiograph. Now, the sorts of diseases that we might encounter on high-resolution CT that will manifest with areas of consolidation include organizing pneumonia, which may occur idiopathically, so-called cryptogenic organizing pneumonia, perhaps better known as BOOP or bronchiolitis obliterans, is organizing pneumonia. Organizing pneumonia can also occur in relationship to drugs, so it may be a manifestation of drug toxicity. It can be seen after infections and that sort of thing. Patients with eosinophilic pneumonia may come to high-resolution CT and manifest with areas of consolidation. Sarcoid sometimes has areas of consolidated opacity as well. And then a variety of neoplasms, particularly bronchoalveolar cell carcinoma and lymphoma, as you know. This case turned out on biopsy to be an area of organizing pneumonia. The etiology was never determined. The patient responded well to steroids. It was probably cryptogenic. Organizing pneumonia therein. Notice this on this particular slide is a pattern which has been relatively recently described in areas of organizing pneumonia, the so-called reverse CT halo sign. In a minute, we'll talk about the CT halo sign of invasive aspergillosis. That's an area of central density with a rim of ground glass opacity. In this case, notice that we have a rim of higher attenuation with a central zone of ground glass attenuation. Again, a relatively recently described finding of organizing pneumonia on high-resolution CT scans. It's another patient with organizing pneumonia, this due to amiodarone toxicity. Notice again these areas of almost mass-like opacity, rim of high attenuation, central area of ground glass, another reverse CT halo sign here. Notice also some scattered nodules. We may see some scattered centrolobular nodules, sometimes branching later opacity, sometimes true tree and bud opacities in patients with areas of organizing pneumonia. With eosinophilic pneumonia, we'll talk about this a little bit more when we talk about airspace disease. Here we have peripheral areas of both ground glass attenuation and consolidation. This was due to drug toxicity as well, high peripheral eosinophil count. And finally, sarcoidosis. In addition to nodules and irregular linear opacities, adenopathy, etc., we may see areas of focal mass-like consolidation, so-called nummular sarcoidosis. And you can see that these areas of consolidation are relatively mass-like. They often have these feathered or spiculated margins. Air bronchogram sign is often prominent centrally, as you see here. But notice that as opposed to the patient with organizing pneumonia, you do not see that central area of ground glass attenuation. Subtle here, but better seen. Mediastinal windows is fairly extensive adenopathy, another clue to the correct diagnosis. Okay, so we went over a lot of material fast. Let me review very briefly. When you look at a high-res CT scan, I make a mental checklist as I go look at the scan. Is there septal thickening? Are there more irregular linear opacities? Are there air-filled cysts? Are there nodules? Are there ground glass opacities? And are there areas of consolidation? And I will base my differential diagnosis on the presence or absence of these key features. But we will appropriately narrow the differential diagnosis by observing the distribution of abnormalities, whether there is or is not evidence of fibrosis, air trapping, pleural disease, or the presence of lymphadenopathy. Okay, we're going to stop right there and more or less immediately, stay on time, move into a discussion of airspace disease, everybody's favorite topic. Now, the problem with airspace disease is not necessarily in the diagnosis of it. I think we can all look at this film and readily come to the conclusion that there are diffuse airspace opacities, but it's rather in generating a relatively intelligent differential diagnosis, because most of the causes of airspace disease are fairly non-specific. It's very difficult on the radiograph alone, for instance, to find and narrow a differential diagnosis. Further, in testing situations, I have observed that it is often more difficult for people to come up with a differential diagnosis for airspace disease than just about anything else. And I think that's simply because of our sheer familiarity with films like this. And the fact that we look at this on the IC board, we typically dictate it out as edema next case. But there are other things that will cause this pattern, and we'd like to at least talk about a few of them. So what I use is a fairly straightforward, down and dirty differential blood pus fluid cells. That pretty much covers everything that's going to fill air spaces. Now, I wouldn't advise you to dictate this particular differential diagnosis. I don't think that sounds particularly elegant. And so what we're going to do is try to flesh that out in the next few minutes as we go along. Now, the other thing that's very helpful in narrowing our differential diagnosis is to know something about the chronicity of the process, because if the process is relatively acute, there's a very different set of etiologies that we would consider than if the process were more chronic, indolent, or insidious. All right? So, for instance, if someone's presenting very acutely with a new onset abnormality, they're acutely ill, we're going to think about causes of hemorrhage, infection, edema, primarily in the fluid category. On the other hand, if the patient's presenting with insidious symptoms, they've got slowly progressive abnormalities on the radiograph, or even non-progressive abnormalities over a number of months, we're not to think so much about hemorrhage and maybe some chronic infections, but not much. We may think about alveolar proteinosis in case of fluid within the air spaces, but then we're going to be shifting primarily toward that other cellular sort of catch-all area of the differential diagnosis. So to illustrate, let me take this case. When I observed the case, I observed there's a fairly homogeneous opacity within the right lung. I think there are a few central air bronchogram signs. I think we would all agree this is predominantly an airspace filling process in the right lung. Now, absent any other information, I might conclude that if this were relatively an acute process, I would consider various forms of pulmonary bleeding. Things that might cause unilateral pulmonary bleeding might be a pulmonary contusion in the setting of trauma, perhaps an infarct in the setting of PE, an underlying tumor that was bleeding, something like that. Other things that might cause bleeding, like vasculitis, may usually present more diffusely. Obviously, I'd be thinking about infection, for lobar pneumonia in this particular case. Edema would not be so high on my differential. Unilateral edema is relatively uncommon, particularly to this degree, unless the patient had had a large pneumothorax that had been rapidly evacuated, or a large pleural effusion that had been rapidly evacuated. I'd be thinking about re-expansion pulmonary edema. At this point, if it was an acute process, I would not necessarily be thinking about some of the other cellular things like bronchoalveolar cell carcinoma, organizing pneumonia, eosinophilic pneumonia, and that sort of thing. On the other hand, if the patient was presenting more with a chronic insidious presentation, say a radiograph a few months ago showing a smaller opacity, now it's larger over a number of months, then I would be thinking about things like maybe chronic infections, tuberculosis, fungal pneumonia, blastomycosis perhaps. Wouldn't necessarily be thinking about edema. Unilateral alveolar proteinosis is pretty unusual. Then I'd be thinking about things like bronchoalveolar cell carcinoma, maybe a pulmonary lymphoma, or maybe one of the other non-infectious, unusual, but non-infectious inflammatory conditions. In this particular case, I happen to know that this was blood. This patient had actually been in an automobile accident. It may be very difficult to see that there's a rib fracture there, maybe in the pneumothorax. This is pulmonary hemorrhage. Differential pulmonary hemorrhage is fairly straightforward. If it's focal, it's usually due to trauma or PE, occasionally an underlying tumor or arteriovenous malformation. If it's diffuse, it's usually going to be due to a vasculitis, such as Wagner granulomatosis, microscopic polyangiitis, good pass-through syndrome, and idiopathic hemorrhage you can throw in there as well. This was a pulmonary contusion. This is a pulmonary infarct. Notice on day one, a fairly large area of peripheral wedge-shaped opacity abutting the pleura. The margins are not so well defined, but by day 4 it's becoming very well defined. This is termed a melting sign. But one of the characteristics of pulmonary infarcts is as they heal, they become more well defined. Now, most pneumonias, as they are treated, become less well defined. Infarcts become more well defined, just like a cubovitis, as it melts, retains that shape, and its margins become more well defined, as you see here. It's another infarct on CT, a peripheral area of consolidation, blood glass opacity. Sagittal reformat shows the clot within the subsegmental artery. Patient with more diffuse opacities here. Nothing specific about this for hemorrhage, except the patient was coughing up copious amounts of blood. They were also in acute renal failure. It's a very acute process. Immediately you're thinking of one of the pulmonary renal syndromes, of vasculitis, Wagner's, microscopic polyangiitis. In this case, the patient had elevated anti-glomerular basement membrane antibodies, such as good pass-through syndrome. We can see a week later it's beginning to resolve. Patient presents with cough and fever fairly acutely. We have a homogeneous right lobe opacity, like perihyolar opacity. Show the CT not to suggest that we ought to be CTing patients with pneumonia, but just to show very nicely a bronchogram sign typical here of an airspace filling process. Again, our differential might be very broad, absent much clinical information, the setting of cough and fever. This is clearly an infectious process that looks like a lobar pneumonia. Lobar pneumonias may be defined as areas of relatively homogeneous opacity that may involve all or part of a lobe. They are typically caused by a group of bacterial organisms such as strep pneumo, H. flu occasionally, Legionella, Klebsiella, etc. It's important to remember, though, some atypical organisms that may manifest with lobar pneumonia as a quote-unquote lobar pneumonia on chest radiographs or CT. That includes primary tuberculosis, maybe we'll start by that, some fungal infections, particularly blastomycosis, coccidioidomycosis, and actinomycosis may occasionally manifest on chest radiographs or CT as a lobar pneumonia. This turned out to be Legionella. Here's a patient with more scattered multifocal areas of airspace opacity. There are probably areas of more interstitial abnormality here. This is one of the reasons that the distinction here from interstitial disease by radiograph or even by CT can be fraught with hazard on occasion, because we know that pathologically both compartments can be involved in either process, in processes that we consider either interstitial or alveolar. But here we have multifocal areas of airspace opacity. Setting of cough and fever significantly narrows the differential. This is more typical of the so-called bronchopneumonia. These are typically more scattered areas of airspace opacity. They're typically multifocal, often bilaterally. The classic organism is staph. They also see this pattern with anaerobic infections, and sometimes with some epidemic forms of mycoplasma pneumonia. This was a staph aureus pneumonia. Just to round out our discussion of pneumonias, we'll show you this case. This patient had dry cough and fever. I think most of us will look at this and probably start down an interstitial differential based on the plain film. We see more reticular opacities here. It will be very hard to suggest that this is an airspace process. But in the setting of cough and fever, we're certainly thinking of an infectious process. This will be a so-called atypical or interstitial pneumonia. These are typically caused by viral organisms. So I put varicella in parentheses, and I want you to put a star by that, because usually varicella, when you see it on a chest film, looks more nodular. The nodules are typically 5 to 8 millimeters in diameter. I don't have time to show you all of these cases, but I'll put this star by that. Chlamydia, and again, this would be P. cerevisiae pneumonia or simply pneumocystis pneumonia. And certainly if this was an AIDS patient, all right, pneumocystis would have to be high on our differential diagnosis. This was a chlamydia pneumonia, which turns out to be one of the more common causes of atypical community-acquired pneumonias if you look for it. A couple other some infections that you should be aware of. Here's a patient with a neutropenic fever. They did neutropenic after pneumonia or something like that for a couple weeks. They developed these rounded areas of opacity, as you can tell. Thin section CT may demonstrate a central area of high attenuation of peripheral ground glass. CT halo sign. Reverse halo sign with organized pneumonia. This is the halo sign, which was described in cases of invasive aspergillosis. Now, you know that this is not a specific finding for aspergillosis. It's been described in a variety of other infections, but in the setting of neutropenic fever, it is fairly specific for angioinvasive fungal infection, most notably invasive aspergillosis. Occasionally, it's been described in Greek word, but that's actually pretty uncommon. This was invasive aspergillosis. Another feature of invasive aspergillosis you should be aware of is the so-called air crescent sign. Another patient with a neutropenic fever, more poorly defined area of consolidation in the right upper lung. You can see 2 weeks later now it is cavitated. We see a crescent of air around a well-defined intraluminal mass. Notice this mass is not grade dependent. This was an upright film. It's adherent to the lateral wall of the cavity. This is the so-called air crescent sign of invasive aspergillosis. And as you know, this is a relatively late finding of disease, usually seen during the healing phase of infection when the lung comes in, tries to clean up, begins to cavitate in this peculiar fashion. You're also aware that this intraluminal mass is not technically a fungus ball. It's actually a piece of sloughed, infarcted lung. All right, it is usually adherent to the lateral wall of the cavity. Here's a pneumonia that's invaded the chest wall. We can see a small subpectoral abscess. And that's a helpful finding. Relatively infections are going to invade chest wall. Actino is probably the most common, nocardia occasionally. Tuberculosis, untreated, may invade the chest wall, as may some fungal infections, particularly blastomycosis. But if you only remember one, remember actino. This was an actinomycotic pneumonia with erosion in the chest wall, subpectoral abscess, and actually a small sinus tract to the skin, which began to discharge sulfur granules. This was a kid who presented with cough and fever. Here, the predominant abnormality is a hilar mass and a homogeneous left upper lobe opacity, which actually represents atelectasis of the left upper lobe. CT scan demonstrates diffuse and extensive, predominantly left-sided adenopathy. Now, as you know, adenopathy is an unusual infection in unusual manifestation of community-acquired infections, and when present, particularly to this degree, should suggest a few particular organisms. TB is the first one you should think about, primary tuberculosis. We may also see it in some fungal infections for histoplasmosis. And then if for high attenuation, we might think of anthrax. No, not really. Won't see those too often, hopefully. Just a word about TB because it is so important. TB results from first infection. It used to be a childhood disease. Now it's increasingly an adult disease in the Western world. It typically presents with areas of airspace consolidation, which may be relatively minimal or involve an entire lobe. The hallmark, particularly in children, is adenopathy. And so when you see a lot of adenopathy, particularly unilateral in the setting of infection, think about primary TB. Cavitation is not. And the other important key point is that any lobe of lung can be affected. So if it's a middle lobe or lower lobe, don't exclude primary TB based upon location. Post-primary TB, on the other hand, tends to manifest with linear and nodular opacities as well as cavitation. Cavitation is seen in a high percentage of cases and, of course, is a hallmark of post-primary disease. This is the form of TB which involves typically the apical and posterior segments of the upper lobes and the superior segments of the lower lobes. Okay. And so when you see a radiograph like this with sort of clustered, confluent, and more clustered and confluent opacities as well as cavitation in that upper lobe of lung, the first thing you got to think about on this study is tuberculosis. This patient has isolated, have to rule out TB. It may be other things. It may be cancer with hemorrhage around it. It may be other infections. But this is TB until proven otherwise. The patient has to be isolated. One final thought. This patient presented to our ED a few years ago and was thought to have a pneumonia. Clinically, you can see a fairly homogeneous opacity here within the lingular segment of the left upper lobe. Was treated, was told to follow up with their local physician in a couple of weeks. They never came back. Here they were 6 months later. You can see what's happened. They've now collapsed the left upper lobe. Classic sickle sign here, left upper lobe collapse due to an endobronchial mass. All right, moving on. This is another diffuse pattern of airspace opacification. Notice the perihylar sort of bat-wing appearance. Again, the differential diagnosis is, in the absence of clinical history, is fairly extensive. You might think about diffuse hemorrhage in certain settings. Aren't too many infections that look quite this homogeneous bilateral and perihylar. In some cases, the severe Asbestos look like this, however. But when I show you a film taken 24 hours later, this is edema. Just about nothing else within the lung is going to, or near completely clear, I should say, this rapidly. That pretty much narrows it down to edema. Now, we really don't have time, and I don't want to bore you with the differentiation of cardiogenic from non-cardiogenic edema. You should be able to general rules that apply. Suffice it to say, this is a form of permeability or non-cardiogenic edema. Our sort of brief differential. There are hundreds of causes of permeability edema. If you only remember one, remember sepsis. Probably the most common cause, certainly in hospitalized patients for permeability pulmonary edema, will be sepsis. Drug reactions and narcotic overdoses are probably more common than we realize as a cause of permeability edema. A host of other ones, high altitude, neurogenic amniotic fluid embolism, fat embolism perhaps being one of the more common causes in patients with trauma, near drowning, acute hypersensitivity, et cetera, et cetera, et cetera. But, you know, there's probably 2 or 3 in the back of your mind: sepsis, narcotics, overdoses, those sorts of things. This patient happened to have been smoking crack. A couple hours before this is a case of crack lung. This is pulmonary edema induced by the opioid inhalation. Another patient with relatively diffuse abnormalities. Chest radiograph, relatively focal sparing, interestingly. The history was a progressive. If we pulled out a film from 6 months prior, we would have seen it look almost identical. Clearly not an acute problem. We're not going about hemorrhage so much here. We might again think about chronic infection, maybe, particularly if there was a little less than narcotic pneumonia or something like that. But even over 6 months, that's pretty long. Now I'm going to be thinking about the more chronic things under the fluid category. I might think about prognosis. And then I start thinking about some of the cellular causes in just a minute. CT scan shows that typical crazy paving pattern we talked about a few minutes ago. Most likely diagnosis. Most likely diagnosis. Hard to hear. Alveolar prognosis, but what else would we consider? Alveolar cell carcinoma with this pattern. Lipoid pneumonia, although we have a fair amount of upper lobe involvement, that's usually from aspiration of lipid material in the lower toxicity. If there was a clinical history of such an agent, of which there wasn't, then a biopsy, this was alveolar prognosis. Patient very similar opacities, frankly. Patient presented to the ED with some cough, fever. They thought she might have a typical community-acquired pneumonia. They treated her with antibiotics, told her to follow up. She came back. She wasn't any better. Kept giving her a variety of antibiotics over the next few months, and you can see 6 months later with progressive airspace. And here's the thing. Differential, blood plus fluid cells, hemorrhage, generally fit, infections. Well, I guess it could be something more chronic like mycosis, perhaps. But really look at that. Alveolar prognosis can progress, can be multifocal, so I have diagnosis, but now I'm going to be getting into that cellular differential, which is really sort of a catch-all. And the first thing there will be neoplasms. And the neoplasms, so we'll do this primarily in bronchiolitis cell carcinoma. We say that on the phone, even though it's less likely. This patient turned out to have multifocal, so-called demonic form of bronchoalveolar cell carcinoma. So another patient with a peripheral area opacity. Interesting. We might, again, go through our differential. I won't bore you with that. Interesting thing about this case, the patient untreated came back 1 week later and now has completely resolved the right-sided opacity and has a new peripheral left-sided opacity. What are we thinking? Okay, when I think about peripheral opacity, I'm thinking about things like infarct, organizing pneumonia. Some of our pneumonias will begin peripherally, but this isn't following that pattern, of course. Another category. Eosinophilic pneumonia. And of those, eosinophilic pneumonia is the one that may manifest with a big area of peripheral opacity. Okay, so tumor cells in the fill airspace, this variety of inflammatory type of cells, which don't easily fit into hemorrhage, etc., and infection. Those include eosinophils, Sarcoidosis, mentioned high-resolution CT talk, organizing pneumonia, and areas of fat with macrophage accumulation, so-called lipid pneumonia. Now, about eosinophil pneumonia, this I think is a very close. I like to classify eosinophil pneumonia syndromes into three categories: those in which known causes can be identified, and those associated with pulmonary vasculitis. Briefly, the diagnosis is made eosinophils within the air spaces, either on bronchoalveolar lavage or biopsy. It would be suggested by a radiographic finding of a peripheral opacity in just a minute, and related peripheral eosinophil is the case. The idiopathic forms include simple eosinophilic syndrome and chronic eosinophilic progressive process. Well, the eosinophil pneumonias that we see are manifestations of drugs that can cause eosinophilic pneumonias. The non-steroidal being principal among them. It has a hypersensitivity response within the lung, but it's also combinations within the lung, etc. The rest of them you can forget. So if you see an eosinophilic pneumonia, peripheral opacities, we think about either idiopathic Loeffler's or chronic eosinophilic pneumonia, or due to drugs or parasites. That's pretty much going to be the template of those that we see in clinical practice. This was a case of Loeffler's syndrome, again, fleeting peripheral opacity. They show up 1 week, show up in a different area of the lung the next week. Many of these cases are due either to drugs or parasites. This one was due to aspergillosis. All the way back to microbiology, you may recall a number of the worms transit through the lung as part of the life cycle. They actually embolize the lung, burrow into the GI tract. And when they're burrowing through the lung, they elicit a hypersensitivity response, which may be manifested as an eosinophilic pneumonia, clinically or radiographic. Now, this was a patient with more of a chronic recessive course with upper lobe opacities. They're low, as you can see here on the CT, and another case earlier in the high-resolution CT talk, patient with a eosinophilic pneumonia. Again, eosinophils, this was eventually thought to be due to ibuprofen use. And one last case before we move on to diseases. This is a patient who was symptomatic, had a history of a resection or partial colonic resection years prior for an adenocarcinoma of the colon, had a routine follow-up, and shows a fairly large area of opacity here in the right arm, as well as some other scattered nodules. Notice on the, it actually looks quite mass-like, alien appearance here, but notice central areas of fat attenuation. This is an area of lipoidia. These are due to chronic aspiration of lipid material. The lipid material sort of sits around and elicits a macrophage response, which may encapsulate hence the soft tissue around this area of abnormality, so-called focal light. The patient becomes sedated chronically since their colonic surgery and was using mineral oil when aspirated is completely of course elicits a cough response. Lipid patients can aspirate it and be completely symptomatic and never cough. Apparently it's very soothing to the respiratory pus. Fluidic cells, we want